Telling you what I think about transverse myelitis in about half an hour. And what we'll try to do is, you can all hear me, right? The microphone's okay? What we'll try to do is do this in about half an hour or 35, 40 minutes, running through some things pretty quickly, and then try to give some time for questions. But if we run late at some point, we've just figured out some ways where we will have time for questions. During today, also during tomorrow, and you can always just kind of run up and catch me and show me a film or ask me a question or something like that for the whole weekend. So if we don't get all the questions asked, I think there will be time for it. I'm just going to move this a little bit so I can get to the computer. So I'm going to start with a case presentation. This is one that I first presented in Baltimore at our symposium, and it's on a little boy, Morgan Gertz. And some of you may have heard of him. His parents aren't here, but Morgan was 12 months old when he was 10 days following a hepatitis B, Haemophilus influenza, and a varicella zoster vaccine. He's a twin who suddenly developed the onset of quadriplegia, couldn't move any of his four limbs, and areflexia, had no reflexes in his arms or legs when he was tapped. So it occurred very suddenly. Morgan had been a little bit irritable, but he and his twin had been fine and went down for a nap together, and it was actually the twin that kind of was upset and was calling, and that's when they found Morgan, who was really floppy and couldn't move anything. And Morgan was taken to a hospital in Colorado where he was found to have complete loss of all sensation that could be detected, and he had no movement of any of his limbs. He was cognitively unchanged. He was alert, he was scared, he was crying. His spinal fluid, or CSF, was done and looked for a series of viruses called PCR studies, were negative. Cultures looking for viruses or bacteria or yeast or fungi were negative. He had we ran some of his spinal fluid for markers of neuronal injury called 1433, which unfortunately was positive because it indicates a more severe injury to the spinal cord, and it was positive. He had a series of evoked potentials, which are looking at the ability of nerves to conduct beyond the level of the injury, which was in his neck, and there was no conduction. So again, pointing to a very severe injury. And I just want to show you three consecutive MRIs. I'm going to back up from this. This is Morgan's MRI in the acute phase. This is a T1 with gadolinium, so the dye was given into the vein to look at acute inflammatory process, and you can see what's going on right there in the neck. There's this swollen area of the spinal cord which is actually acutely inflamed. When you look at subsequent MRIs, you can see that that is gone. There is no inflammation anymore, but you can see that the cord has narrowed, it's atrophied, indicative of a very severe injury in Morgan's case. So these are three consecutive MRIs over many weeks. If you look at the spinal cord in cross-section, you can see a similar thing. Here is the spinal cord here. Many of you have been tortured to look at these when you had no interest in so doing. But this is the spinal cord, and this is the spinal cord much later in Morgan's case. And it has withered away because of the injury in that acute phase. And unfortunately, Morgan died. There was nothing that could be done for him. And we looked at the tissue in Morgan's spinal cord, and I'm not going to go over all of the details of this, but his cord was completely necrotic, dead. There were no surviving neural elements through that area of injury in the neck. And yet above that and below that was completely normal tissue. It was just something which I had never seen at the time, and was just stunning to me to see. And it really kind of solidified for me that we need to understand this, and it's kind of solidified my role of furthering this research as best we can to make sure this doesn't happen. Although it's the most dramatic case that I probably have yet seen, there are many others of your children who are similar to that to lesser degrees, and it provides to me the same impetus that we've really got to understand this disease better. So I want to convey to you some of the stuff that we're doing now to get there. We don't have a lot of the answers, but we're trying, and I think we will. So I want to do a little review for some on the terms that you hear, because you hear these terms in websites and your doctors are saying this, and I just want to make sure we're all on the same page. So a neuron is a specialized cell which conveys electrical impulses, allowing for coordinated behavior such as sensation, language, motor, etc. Specifically, if I want to move my right toe, a neuron fires an electrical impulse on the left side of my brain and sends that electrical impulse down an axon. An axon is the long wire coming out of that neuron. And that goes down the brain stem, crosses over into the spinal cord, and keeps going. So that axon is 1.5 meters long, but is carrying that electrical impulse. At the base of the spine, it synapses or fires a chemical input to another neuron, which then fires an electrical input down to the leg, where it twitches onto the muscle in my toe, and that toe moves. So that's the motor pathway. It's a descending pathway so that I can move based on 2 neurons firing from the brain all the way down to the toe. Sensation is similar in that if there is a cold object placed on my toe, it triggers a neuron in the skin right down on my foot, which fires an impulse up an axon into my spinal cord, up to my brain, where it is received as saying, hey, there's a cold object on your foot, move it. Okay, so that's really an ascending sensory pathway, then there's a descending motor pathway. An axon is just the wire which carries the electrical impulse. Oligodendrocytes you've heard about. Oligodendrocytes are myelin-producing cells which insulate and nourishes axons. What they do is they provide the insulation around the electrical wire, which is the axon. And by insulating that axon, they allow it to fire appropriately. If the insulation is gone, or there's demyelination, what happens is that electrical impulse doesn't fire appropriately. Sometimes it doesn't fire at all. Sometimes when it does fire, it gets the message wrong. And so your children will say, there's pins and needles on my skin, or there's pain. And that's all really aberrant firing of impulses because of demyelination. Axonal injury is another form of tissue injury. Unfortunately, Morgan had both, but axonal injury is when the wires themselves are injured. It's a more severe form of injury, and unfortunately at this point is less transient. It tends to be more permanent because we can't really remake axons and neurons yet. So demyelination is the loss of myelin sheath around the axons. So neurons can be motor or sensory, just as I described. Neuroglia is another term for all of the supportive cells in the brain and spinal cord. Astrocytes, microglia, ependyma, oligodendrocytes. We're not going to talk about really any of these other cells. I just mentioned to you oligodendrocytes. Those are the ones that do the myelination. Blood vessels are in there as well. This is a picture of the spinal cord. This is a beautiful neuron with all of the axons. You see, they really actually look like wires. So these are thousands of axons going out from these neurons and going into these neurons in just one tiny section of the spinal cord. Okay, so I've done a little bit of the ascending and descending pathways. White matter tracks are the descending pathways and ascending pathways. So they're the highways up and down the outside of the spinal cord, which are, it's just a relay station of input. Whether that is a relay station of motor input down to the leg or sensory input up to the brain. Then there's gray matter, which is at every level of the spinal cord. There are cells that are the ones that go out to the muscles and are called the ventral motor neurons. Those are at all levels of the spinal cord. All right. So, how about acute transverse myelitis, or what I'll call ATM? It is an acute inflammatory disorder of part of the spinal cord. The immune system has one task, and that task is to distinguish self from non-self. For those of you who've come to see me, you've heard this. Everybody who's seen me in the clinic kind of hears the same spiel. So if I see people kind of nodding off, I know it's because they've probably been to see me in the office and they've heard this. The immune system has to do one task. It differentiates self from non-self. Its task is to recognize foreign invaders, bacteria, viruses, and to attack and eliminate them. That's what our immune system does. So what happens in transverse myelitis is that that immune system becomes deranged. Deranged in that it attacks your own tissue when it shouldn't do that. The mechanisms that lead to that derangement we don't know yet, although we're starting to get there. So it is immune-mediated. The clinical ramifications of that attack on the spinal cord are that there are 4 symptom groups. 1, motor dysfunction. So those descending tracts which allow you to move well and in a coordinated fashion are disrupted, resulting in weakness and spasticity. Sensory dysfunction is disruption of the ascending sensory tracts. Can lead to numbness, paresthesias, which is often a pins and needles sensation, or dysesthesias, which is an uncomfortable sensation, mediated by the short-circuiting of ascending sensory nerves because of demyelination. Autonomic dysfunction, sexual dysfunction, bowel and bladder dysfunction, and finally pain. Those are the 4 symptom groups. It is typically monophasic, one phase. So the derangement of the immune system, as best we can detect it, is gone after that short period of time. It is triggered to attack self-tissue, specifically the spinal cord, after which the immune system kind of rights itself. So as best we can tell, months and years later, there is no ongoing inflammatory attack in most people. In some there is, and I think we can try to understand that. We can predict that fairly well in the acute phase, who will have a recurrent transverse myelitis, though that's the minority of people. Now this should be distinguished from, for example, multiple sclerosis, in which there is it's a multiphasic process. So multiple sclerosis, there is this ongoing attack of your own tissue. So there is no correction of the immune system. It is usually monofocal. So one region of the spinal cord, not multiple regions of the spinal cord and brain, although there are very related disorders. Post-infectious encephalomyelitis you heard about last night, acute disseminated encephalomyelitis, and multiple sclerosis are on probably a similar spectrum. DeVick's disease is another one. These are all on similar spectrums to acute transverse myelitis. What we think of after the acute inflammatory response is that this is really a non-traumatic spinal cord injury, to kind of link it to traumatic spinal cord injury. There has been no diving accident or motor vehicle accident, but long after the acute inflammation, it's gone. There is no inflammation. There would be no enhancement of the spinal cord, but you're left with the sequela of that inflammation, which is similar in terms of what's happening in the spinal cord to that with the traumatic spinal cord injury. So why does the immune system go bad, or what we call immunopathogenesis? There are several emerging theories, and many of which are starting to gain a foothold in transverse myelitis and those related diseases. One is called molecular mimicry. The dastardly virus that infects you actually has on its surface proteins that look like the spinal cord. So it mimics the spinal cord. It purposely does this so as to get the immune system directed away from attacking the virus or the bacteria. This is well known to be a cause for Guillain-Barré, which is also a similar disease. You get a bacteria in this case called Campylobacter that causes diarrhea. No big deal though, the diarrhea goes away, but some strains of this bacteria called Campylobacter actually have mimics to myelin on peripheral nerves, resulting in the subsequent development of Guillain-Barré syndrome. And that also occurs in transverse myelitis, a dastardly deed. Superantigen-mediated disease is probably what happened to Morgan and several others, in that there are particular proteins, again, secreted by a virus or bacteria that trick the immune system and trigger it into becoming very activated to a whole series of substances. I won't go into this too much except to say that all of us have immune cells in our body which are reactive against our own tissues, but they are kept quiet. Hence, we all don't have autoimmune diseases. But what happens when a superantigen, this very strange protein, gets into the immune system is it activates all of those lymphocytes, causing an autoimmune disease, transverse myelitis. I should say that it's probably very similar, and you're going to start hearing this, to diseases such as thyroid disease, Hashimoto's thyroiditis. Diabetes also are triggered by some of the same things. The idea is that you then activate autoreactive lymphocytes, which are called T cells, B cells, natural killer cells, and in many cases the immune system derangement results in the production of autoantibodies, or antibodies against self-antigens or self-proteins. No matter what the trigger, there is a sequence of events that then follows in the spinal cord. The hallmark is, of course, inflammation. I don't want to block anybody. Inflammation is infiltration of the spinal cord by lymphocytes and macrophages, resulting in tissue and vascular injury. This is a spinal cord. This is a focus of inflammation that shouldn't be there. The inflammation itself is not injurious, but it results in the pathologic sequela, demyelination, and necrosis or axonal injury. So once these inflamed, activated lymphocytes are in the spinal cord, they start secreting things and attacking things. Those inflamed lymphocytes think that this is foreign tissue right now, and that's what they're designed to do, is to fight foreign invaders. Demyelination is damage to myelin-producing cells. What you're seeing here is a cross-section of a spinal cord. The white matter is around the outside. It is paradoxically blue in this stain, but you see all of these spots here? Every single one of these spots is an area of demyelination. It should be blue all around the outside, and it's not. Necrosis or axonal injury is the other tissue reaction to inflammation. Tissue damage secondary to vascular changes and or inflammation results in the more serious form of neuronal or axonal death, which has been widely considered, at least up until the last several years, to be irreversible. Now I think we're starting to think that neither of these is completely irreversible, but certainly this is the tougher task of the two to restore. So many of you have heard that this is a para-infectious, and that's what I mean by that. It is the infection which triggers this deranged immune response. It's not necessarily that the infection is in the spinal cord. It's just an ear infection, or an upper respiratory tract infection, or diarrheal illness that then triggers the immune system to go bad. And so the infection leads to inflammation and a vascular reaction leading to the demyelination and or axonal injury. Okay, so let's talk about some clinical aspects of acute transverse myelitis. It is a very rare disease, so 1 to 8 per million is the published incidence per year. So your child can be said to have a 1 in a million chance of having gotten this, and that's probably fair. So 1 in a million is pretty rare. Take, for example, multiple sclerosis, which we hear about, which is probably 200 or 300 cases per million people. So it's about 300 times more common than would be transverse myelitis. So if you extend that out to the population in the United States, it's about 1,400 new cases per year. 34,000 people at any given time are suffering from sequela or morbidity from transverse myelitis. So there is a large community, most of which Sandy has spoken to personally. Is that right, Sandy?
Usually during dinner.
Now, this is This is just what we think of. The differential diagnosis is our way of saying, well, what else could it be? These are the things we have to run through. Trauma is something that you always think about, especially in a very young infant on whom you can't really get an adequate history, because this is obviously different from a traumatic spinal cord injury. Multiple sclerosis, although certainly not in very young, but as an adolescent, this could be the first presentation of multiple sclerosis. A compressive myelopathy, usually in older people from arthritis or disc herniations. Sometimes tumors or paraneoplastic, which are factors secreted by tumors that induce a myelopathy or a spinal cord disorder. Sometimes a B12 deficiency, or an autoimmune process causing vasculitis or inflammation of the blood vessels will cause this. These are the things that we've got to think about. Ischemia could be a spinal cord stroke, could be an abnormal blood vessel collection, a venous thrombosis or clot, hemorrhage, or an inherited disorder. Most of these we can pretty much kind of go down the list and say yes or no to, so that there should be some certainty as to the diagnosis of transverse myelitis. Unfortunately, as many of you know, that's not the case. That a lot of people don't get a definitive diagnosis and are kind of left saying, well, we're not sure what this is. This is how we think about it, and we think that about a large range here, 6 to 45%, but probably around 30% are para-infectious, just as I've described. They follow an infection. 30 to 40% are MS, but typically in an older population, not in children. Ischemic or vascular, meaning it's a stroke of the spinal cord. Autoimmune disease, this is one of the things that it's very important to look at, actually even in children. Lupus, sarcoidosis, and Sjogren's syndrome are autoimmune diseases that are systemic and cause transverse myelitis as part of their presentation. What's critical is that these can often be multiphasic. Unlike acute transverse myelitis, the idiopathic or the uncertain form, this form is actually can be recurrent. So it's important for us to define this, and sometimes radiation. But about 1 in 5 we never do find out, and we call it idiopathic, meaning we're idiots. We don't know. It just means we don't understand, and we're hoping to get that number down. So the etiology remains unknown. It is probably a heterogeneous disorder with several different causes. So each individual is different with different triggers and then different inflammatory responses. So I doubt that at one point we will find the cause for acute transverse myelitis, just as I doubt we'll find the cause for multiple sclerosis, which I think is very similar in that it's multiple different disease subtypes. Probable causes include direct microbial infection in some. Sometimes the virus, such as a herpes virus, will get into the spinal cord. More often than not, it's the reaction, the inflammatory reaction against it. Post-infection immune reaction is what we've been talking about, and vascular injuries. So, these are the things that we think about in the acute phase. IV solumedrol, many get this. We think it works. There is no randomized controlled study which says that it does. However, in many of these other diseases which are on the same pathophysiologic spectrum, steroids do work, and we give it to most people. Antibiotics directed against bacteria or viral agents can be given sometimes. Plasma exchange is something which will often be done, especially in a severe case in which steroids don't seem to be working. And here we are a week later, and there's still very little movement, very little response. We'll initiate plasma exchange. Cytoxan, mitoxantrone, and maybe even CSF filtration. This is a new therapeutic approach which we probably will try in clinical trials at Johns Hopkins over the next couple years, is a way of actually filtering the spinal fluid of inflammatory mediators, and is actually fairly simple to do. Now, as part of a consortium that we've established, we've really set up inclusion criteria for transverse myelitis, and we've done this so that very quickly, wherever somebody is, they can kind of figure out the same thought processes that we've just gone through, and to sort out which of these various disease categories this fits into. Could it be something else in transverse myelitis? And if it is transverse myelitis, what type is it? Because that affects what you're going to do in the acute phase. So all of the doctors here, as well as several others, we've all gotten together and locked ourselves into a room and established these criteria for what constitutes transverse myelitis. This is now actually coming out in the literature over the next, I think in a couple days actually, this paper will be out. It's been accepted for publication. I think will kind of change the way doctors think about transverse myelitis. At least I hope so. I'm not going to go through all of the criteria. It's not really germane to this here, just to say that this is really how we're conceptualizing transverse myelitis. And as importantly as exactly what those criteria are, is this. Now, you can't read any of this, but you're not supposed to read any of this. This is really an algorithm for ER docs, essentially. How they need to think about this, and this is on our website, and I think it's also on Cody's website. I don't know if it's on the myelitis.org, but it already has worked in that we'll get calls from ER docs wherever who have looked at this and have said, okay, I've done my history and physical examination, I've gotten this information, I've now ruled out a compressive etiology by an MRI, now what? And it kind of guides people, physicians, down this path. And the end result is you get down here. You can't even read that, but that's okay. It kind of tells you, is this multiple sclerosis? Is this a particular type of transverse myelitis? Is this de Vick's disease? And therefore, quickly, where do you go? What do you do? What do you institute? Even if we don't have all the answers in terms of what therapies are available, this has helped, and so I think this is a valuable service. So we have a center, a transverse myelopathy center, where we look at transverse myelitis and all of its subtypes. I'm going to tell you about some of the activities that we have going on there. Chitra Krishnan is the center coordinator. Many of you have spoken with her. You should feel free to call her, email her. In fact, I'll give you her email right now. Ready? C KRISHN 1 at JHMI, Johns Hopkins Medical Institute.edu. So if anybody wants, for example, these slides, you want to go out and give this talk on your own, you're welcome to. She'll get the slides to you. If you just want some information, you want to come see us, that's the best way to do it. She's in India now for a couple weeks, but she'll be back. All right. This was established in October of 1999, really thanks to Gunny. Many of you may know Gunny, Aunt Sandy, who was pushing for this and really kind of impressed upon me the need that, to start to study this in a rigorous way. Lots of people at Hopkins and elsewhere were very interested in doing this, and so we've just started to get some answers. What we do as we see patients is often try to involve lots of different disciplines. I'm a neurologist. I primarily see adult patients. We have pediatric neurologists, physiatrists, urologists, neurosurgeons, rheumatologists, and anesthesiologists. All have interest in this. All are interested in kind of putting parts of the piece of the puzzle together. We have now evaluated over 250 patients, and we've gathered information. We haven't made any stunning findings at this point, but we're still kind of in the information gathering phase. The only way that we're going to start to make inroads is to really get at what everybody presents with and what it looks like and what does their spinal fluid look like. And so we've started to do that. And I'm going to move through this because as the moderator of this session, I cannot be late. So, and I think I'm actually going to skip this. There are lots of ongoing projects looking at the spinal fluid for various inflammatory mediators, at looking at clinical characteristics which will help us uncover causes for it. We're looking at a variety of immune derangements in the T lymphocytes and B lymphocytes, and we think we've actually found several novel immune derangements that characterize the acute phase of transverse myelitis. Stay tuned for that. Okay. What we know, I'm going to skip to the pediatric aspect. What we know about the clinical characteristics is 75% of the patients who get transverse myelitis are adults. 25% are children. Now, Frank, are you going to talk about some of this? No. Okay, so I'll go over a little bit this. The average is 35 years, plus or minus 1.9. There is higher rates. There are two peaks of when transverse myelitis occurs: 40 to 50 years of age and less than 10 years of age. And those are probably very, very different diseases that are called the same, but everything else about them screams out that they're different diseases and they need to be studied separately. And so we're starting to do that. Now again, antecedent factors. We're going to talk a little bit about vaccines. If you take all of the patients who have come to our center, 15% received vaccinations less than 30 days prior to their acute onset. No specific vaccine types were predominant. This was obviously much higher in children. We don't know the significance of it, and we'll talk about it this afternoon. 35% had a preceding illness characterized by fever, which is this para-infectious cause that I've been talking about, and in many cases there was traumas defined by a back sprain, a twisting, a pulling, which in many cases was followed by a sense of warmth or pins and needles sensation. It wasn't a clear-cut traumatic injury, but there was some twisting or turning to the back. It took about 4.5 days for a patient to start to get to their worst, although in some cases it actually progressed over hours rather than the 4.5 days. Again, I'm going to skip through this. Sensory function. I told you about the 4 symptom groups, right? 91% of patients had numbness. 97% of patients had these paresthesias, these uncomfortable sensations. Pain in 68%, and a clear-cut sensory level in most. How about bladder function? Well, most, 2/3 actually, required intermittent catheterization. Sexual function was abnormal in 83% of patients. Motor function, at their worst, people couldn't even walk. This was the average of all of the patients that came to see us. And I'll give you some follow-up data. Again, I will provide this to anybody who wishes it. So following the acute phase, we said, okay, how do patients do on average? So median motor score improved so that people were able to walk more than 30 feet unassisted, but actually could not do manual work on their own. 37% had pain. So it's a big issue in our database, is that there's persistent pain long after the acute inflammation has resolved. 62% had sensory deficits. 56% had autonomic dysfunction characterized by bowel, bladder, or sexual dysfunction. 35% actually needed long-term catheterization. Now, if we just look at the pediatric population, we had 28 out of the 111 patients at this one time point that we looked at. We've got more of those now. Were less than 18 years old. Mean age was 8 years. 36% of the patients were less than 2 years. And now the vaccine rates were higher. 32% of those patients had a vaccine within the preceding 30 days. And there's long been a historical argument that the vaccine could trigger an immune response which could cross-react with the spinal cord. And we still don't know the answer to that, but we'll talk about it later. In children, it progressed more rapidly. Mean time from the onset of symptoms to the worst was 2.6 days. So it was a much quicker disease in children. If the disease progressed more slowly, it actually predicted a better outcome in children. Now, we've looked at some outcome measures in children alone. This is really done by Frank Pidcock. So we've looked at where children are specifically. In terms of self-care, 76% are independent, 29% are independent with sphincter control. So most kids still cannot control bowel and bladder very adequately. 2/3 can transfer, 67% independently, and 62% can actually locomote independently. Now, I think I'm just about done. I'm not going to go into all of this because I haven't gotten into it all symptom management. That is, after the acute phase, there's been an injury. The injury consists of demyelination and axonal injury. We're left with those 4 symptom groups that persist. How do we manage that? What do we do to maintain the child at as high a functioning status as we can? Because the truth is we cannot get rid of them at the current time. We hope that we will, but we can't. And so certainly during breaks or some other time, I'll go over kind of our whole approach to, general health, overall health, bladder dysfunction, weakness, pain or dysesthesias, bowel dysfunction, and spasticity. Because for each of them, we really need to start a graded series of interventions so that we can maximally control those symptoms with the least amount of medicines, looking at the child as a whole. And it's a very complicated task, but what you don't want is a doctor who just says, well, hey, listen, that's it. This is your lot in life. Deal with it. Because everything needs to be really managed in an aggressive way. And maintenance of health function is not trivial. It takes a very active effort on parents and child part. It just doesn't happen. This has to become a major part of your life, and it shouldn't have to. In normal children it doesn't, but it does here. And so this also requires a healthcare team who's got that same approach. Now, I want to do 2 or 3 more slides. I'm going to take off my clinical hat and walk over to the laboratory now where we're looking at research because the medicines that we have now are okay, but they're not curative. And what we're hoping to do is to develop better treatment strategies. And many of us in the medical profession are looking at stem cells and other new therapeutic avenues. And in fact, what we'll probably do is start initiating clinical trials of new interventions for children and adults with cell-based therapeutics, looking to ask cells to remyelinate the spinal cord, or maybe even to make new neurons. Now, this isn't going to happen soon. This is not going to happen in the next 2, 3, or maybe even 4 years. But once you start getting out 4, 5, 6 years, it will happen. And already we've got these tantalizing data in animals that you can do it. You can use cells, some stem cells and other cells, to actually remyelinate or make new neurons in the animal spinal cord and to restore function. So it's actually not a bad time if you're a rat to get a spinal cord injury. That doesn't really translate yet into humans, but it will. I'm not going to go over all of this data. This is work that we've done in rats using stem cells. And what you probably won't be able to get, but I'll go over very quickly, is that this is a stem cell. I know it's a stem cell because I've looked at it with a particular antibody which defines it as a stem cell. The green, the red indicates that it has turned into a neuron in this animal's spinal cord. So we've had a paralyzed animal, we've placed these stem cells into the spinal cord, and this stem cell has turned into a neuron in the spinal cord. It gets even better in that these stem cells can actually turn into motor neurons. So these are the particular motor neurons that are often damaged in the spinal cord. Not only that, but it will actually send out processes out of the spinal cord in order to contact muscle, which is exactly what a motor neuron should do. So by all of these criteria, these stem cells have gone into the spinal cord and have started to establish the appropriate connections that it needs to. Now, so this is one of those animals. Some of you have seen this. This is a paralyzed animal, actually mainly in the hind limbs. Its forelimbs are relatively preserved. This was a virus that we used to induce this degree of paralysis. And I'm going to show you the same animal now that is 4 months after transplantation with these stem cells that we used. And it's actually obviously doing much better. So the animal now can get its hind limbs underneath it and can waddle. It has got an abnormally shaped back, so it's developed this kyphoscoliosis. We don't know exactly why that's occurred. The animal actually still collapses a bit, so it's not strong enough to be able to bear weight on those hind limbs, because when it tries to, the hind limbs give out. But it's still better. So this is where we're going, and that's actually looking at kind of neuronal replacement. And I've told you that's a taller order. What will be easier to do will be to remyelinate demyelinated axons. And that's something that you're going to start hearing about. So the approach I take is I can't do an awful lot now in some cases. But what we can do is be very aggressive, maintain health, do everything, look at all of those symptom groups and treat them as aggressively as we can, because better days are ahead. It's not right around the corner. It's 4, 5, 7 years away, but it will come. And I think most people feel that you will be able to restore some degree of function. It's not going to be like a pill that then you get up out of your wheelchair. But even incremental recoveries would be very, very meaningful. And so we keep working, and I think better days are ahead. I think I'm done. Thank you. Oh, that's Caroline. You've all seen her. That's her best friend, Madeline. Had to put her up there. Thanks.